Okay, this is Dr. Hall. We're going to move into Unit 10, talking a little bit about healthcare organizations. So I'm going to structure this lecture a little bit differently than the book does. My computer is making weird noises at me, sorry. And so the way I'm going to look at it is we're going to talk a little bit about the scope and diversity. What are the healthcare organizations that we have in our country? Then we're going to talk a bit about access, which is not something that the book covers, quality, and then ultimately coordination, which is also a little bit different from the textbook. So let's talk about the scope and diversity. So what are the healthcare organizations that we primarily have in this country? Okay, so first we're going to talk about inpatient facilities, and I needed to retake this slide because things have changed a little bit here in our region. So inpatient, remember these are places that you stay overnight. This is what we think of as hospitals, and there are some other places where you often get medical care or healthcare where you are also staying overnight. So let's take a look. So here's the list of hospitals, the different types of hospitals that exist. Let me get my highlighter here. And so the first thing we're going to talk about is general hospitals. So this second one here. These are kind of your typical, average, everyday hospitals. These are places where you can get most of the care you would ever need. So most of us at some point in our lives might need to stay overnight in a hospital. Chances are our needs are going to be met by a general hospital. These are places where they can take care of you for your heart attack, your pneumonia. They can do your knee replacement surgery, your hip replacement surgery, you're in a car accident. They can probably take care of you. They have an ICU if you get really sick with COVID or sepsis or something like that. So that's your general hospital, and it's not just a soap opera from days gone by. And our closest one here to Menominee is in Eau Claire. So Mayo Clinic Health System has Luther Hospital, and Marshfield Clinic Health System also has a hospital in Eau Claire. So there are two general hospitals in Eau Claire. There used to be three. That's going to come up again later in this talk. So what we have here in Menominee is different. So we have a critical access hospital. So these are hospitals that are in smaller towns. They do not have the same full suite of services. So they often don't have an ICU. They often don't have the full suite of specialists. They don't have cardiologists. They may have an orthopedist there 1 or 2 days a week. And if the day that you happen to break your ankle and need a surgery is not a day that they are there, you're going to get transferred to the general hospital. They may or may not have birthing centers or labor and delivery facilities for delivering infants. Here in Menominee, we had one until just a couple of years ago. It recently closed. That's going to come up again later in this talk. So critical access hospitals are smaller rural places that can take your appendix out. They can often do a knee surgery if you need your knee scoped for something. They can take care of you overnight if you have bad pneumonia. But if you have something really more intense, needs a higher level of care, or needs a specialist that is not available, then you're going to go to the general hospital. Now, sometimes you need an even higher level of care. Sometimes you have a really unusual cancer or a really unusual infection, or you need a really specific type of open heart surgery. And if that's the case, then you're going to go to a tertiary care hospital. So these are the deluxe hospitals that have every type of specialist you could possibly want. So our closest here to Menominee would be certainly in the Twin Cities, and then of course the big Mayo Clinic Hospital down in Rochester, Minnesota would be the closest ones. Certainly Madison, Milwaukee, they all have tertiary care hospitals as well. The last one down here is specialty care hospitals. So specialty care hospitals generally are those that have decided they're only going to take care of a certain subset of things. So Cancer Centers of America, for example, they have hospitals and clinics that just treat cancer. St. Jude's Hospital in the Twin Cities provides free care to children that have cancer or other medical conditions. So they just focus on the care of children. So there's in New York City, there's a special hospital for joint surgery or something. So there are some specialty hospitals that only treat certain types of things. Okay, so those are the hospitals that you go to if you are sick, and that you may stay in overnight, inpatient facilities. We also have some other places that you may be getting healthcare that are residential, inpatient, where you sleep there at night, you're there overnight. So the first one I'm going to talk about are these skilled nursing and rehabilitation facilities. So skilled nursing means that they have nurses on staff, they have medical folks there, and their goal is rehabilitation. Their goal is that you are going to get better to go home. So say, for example, you fall and break your hip, you have that hip repaired at a general hospital, most likely. And then after the surgery, you're not quite ready to go home. You still need some intensive physical therapy. You really can't move around by yourself yet. You can't get to and from the bathroom by yourself. So a lot of times you're going to go to a skilled nursing and rehabilitation facility, sometimes called a SNF, SNF for skilled nursing facilities. And you'll be there for a couple of days or sometimes a few weeks while you further improve, right? You didn't need the intensive medical care of a hospital, but you're not ready for home yet. And so you're going to be there on a temporary basis as you improve and recover so that then you can go home. So the thing about a skilled nursing facility is that the plan is you are going to go home, and the expectation will be that you're making gradual progress. Now, if you need more medical care on a long-term basis because you're not getting better, that's where nursing homes come in. So a nursing home is meant to be a place where it's not really expected that you're going to improve. So you may be very elderly, you might have dementia, or you might have a medical condition that really impairs your ability to get around and care for yourself. So you need health care just on an ongoing, regular basis, and it's not expected that you will improve. So that's what nursing homes are. Now, it's a little bit confusing in our country because often, I think this is the next, oh, no, sorry, I'm going to say one more thing. So the third type of facility that we often hear about is assisted living. Now I put them on the slide because we think about them as places that people go and stay, but they're not usually truly healthcare organizations. So assisted living places, they're often apartments. There may be a centralized meeting hall where they have congregant meals where you can go and have lunch. They may have activities programmed. They may even have people who stop by and make sure you've taken your medications every day, people who come in and clean your apartment for you, perhaps, maybe even offer some assistance with bathing or toileting or helping you with your groceries. But assisted living facilities, by definition, are not required to have like healthcare professionals working on site. Some of them do, just to make it even more confusing. Some of them do have nurses on site and or have a physician that comes in regularly to do visits, so it can get complicated. Now, to further complicate things, nursing homes and skilled nursing facilities are often physically in the same place, and that's because they need the same types of infrastructure, same types of staff, often same types of professionals working there. So very often in the United States, a nursing home and a skilled nursing facility will be in the same physical building. They're technically different services with different objectives and different goals and purposes, but they are often in the same actual physical location. And to make it even more confusing, sometimes some of those places will also have an assisted living. So they have like this full continuum. And so sometimes people will kind of buy into these places. They start an assisted living, and then if they deteriorate medically and they need a higher level of care, right, they can move into higher levels of care as needed. So that's kind of the general spectrum of inpatient facilities that we have in the United States. In terms of outpatient facilities, we have a whole huge mishmash of different types of things. So the solo or small practice, the old country family doctor of yesteryear, where that just they called it hanging a shingle. You just put a sign out, the doctor is in, and people would come see you in your little office, and you might have a secretary or a nurse assisting you. That mode of practice is not a financially sustainable model in most cases, although not all in the United States. And so those solo practices are increasingly uncommon. You do still sometimes find them, and also small practices where it's a couple of providers working together. We still do see those in terms of optometry offices, dental offices. They're pretty common still because the financial models are a little bit different for those, and it is a sustainable way to practice. But for medicine, it doesn't work very well most of the time anymore. You sometimes do see small group practices for physical therapy. Oh, of course, chiropractic is often a solo or a small group practice as well. Then there are multi-specialty groups. So this would be groups of healthcare providers. You might have some primary care providers, such as pediatricians, internists, family doctors, and maybe a couple of surgeons or a gastroenterologist or some OBGYNs kind of coming together to form a larger practice. So these multi-specialty groups. Oakleaf in Eau Claire is an example of a multi-specialty group. They are not owned by a hospital or a large health system. They have formed their own kind of mid-sized organization or corporation. And then the biggest one is the health system clinics. So for example, Mayo Clinic Health System operates a big clinic here in Menominee. We also have a small clinic that's operated by Marshfield Clinic. So Marshfield Clinic is a big, huge health system, and so they have a satellite clinic here in town. So health system clinics are for most of medicine, a more financially viable way to organize, especially primary care, as well as other outpatient services. So we're kind of seeing more and more of those. The fourth group that I have here is community health centers and free clinics. So there is some governmental support for these types of efforts, which are usually targeted toward people who don't have health insurance or who might be on Medicare and Medicaid and are unable to access care at some of the other facilities for reasons we'll get into in a minute. So yeah, those can be great adjuncts to how we bring care to the population. So this kind of brings up this idea of, well, how are they funded? So all of these healthcare facilities are primarily funded by reimbursements from the patient's medical insurance, right? So their health insurance pays, and then whatever the health insurance doesn't pay, then the patient is responsible for. So we have kind of two main types of insurance. There's private insurance, which is usually insurance that you get from your employer if you're benefits eligible and your employer offers that to you as a benefit. Or you can get it through the marketplace. So recall the Affordable Care Act established these healthcare exchanges to make it easier for people to get health insurance who didn't have access to it through an employer. And so those people are also on what are termed private plans, as opposed to, for example, public insurance. So these would be programs like Medicare and Medicaid. We'll talk about these more when we talk about health insurance. In the state of Wisconsin, Medicaid is often referred to as Badger Care or Forward Health, so you might know it by those names. Public health insurance is usually provided to people who are low income, right, or no income, or permanently disabled. And so it's paid for by the state, generally in conjunction with the federal government. It's kind of complicated, but it's paid for by the government using taxpayer dollars. And so, of course, these programs aim to be as cost efficient as possible, but that also means that oftentimes, especially for outpatient care, the amount of money that they pay the doctor or physical therapist or whoever they may be is often less than the cost of care. So what happens is that oftentimes, for example, if a physician opens a practice, and usually if half or more of their patients are Medicare and Medicaid patients, they will go out of business because they don't collect enough revenue to meet their operating costs. So it gets a little tricky, especially in the outpatient realm, especially in primary care. And of course, patients themselves. So depending on your health insurance plan, you most likely have co-pays, co-insurance, or deductibles, all fascinating things we'll talk about in the next unit. And then, of course, any other costs that are not covered by the insurance plan for whatever reason, including perhaps that you don't have one, right? So if you don't have health insurance, then the bill is coming to you, and whatever you pay to the hospital or the clinic is helping to fund that hospital or clinic. So healthcare is really expensive in this country, and there are many reasons for it, and some of them are unique to the United States and some of them are not. So a few of the reasons why healthcare is so expensive, because it's super complicated, is one is that staffing, right? So these are highly trained professionals who are making high salaries, right, in order to be competitive in the market. And in order for them to be able to pay off their medical school loans, you have to pay them a certain amount of money. So, highly trained personnel that require high salaries. So that's part of it. It's interestingly a small part. Equipment and supplies is not insignificant. So a standard exam table, for example, for a primary care office costs about $2,000. Which is kind of crazy to think about. Um, so, everything from the swabs for swabbing people's throats to the sinks in every room, to the speculums, to the gloves, to the masks, to the blood drawing equipment, to injection equipment. If you're going to be freezing warts, the little cryo gun for the liquid nitrogen. And if you're a surgeon, well, then you're going to have all other kinds of supplies. If you're a hospital, you're going to have emergency rooms and ICUs that have incredibly complex and expensive equipment and drugs and medications that you need to provide. Operating rooms are exceedingly expensive to kit out, to outfit, to supply, and then to maintain. So you've got highly trained and expensive staff. You have really expensive supplies and equipment that you need to purchase and maintain. And then, especially in the case of hospitals, you need to have this equipment and staffing available at all times, or hopefully available most of the time, because you're trying to meet the demand for care, right? Your goal is to improve care to your population. You're a nonprofit organization most of the time. But if you have a hospital bed sitting empty, you are not collecting revenue, right? So think about it as, you're still paying a nurse because somebody might come in and need that bed. But so it gets really tricky because you have to maintain some excess capacity. Oftentimes in the United States, we would say that we don't maintain enough excess capacity, and part of that is because it costs you money. But the other reason why healthcare is so expensive in the United States, and there are more reasons than this is just a sampling, is that many bills go unpaid. So in fact, when it comes to hospital bills, it looks like probably at least half of them never get paid. Why do they never get paid? Well, because people don't have health insurance, or if they do, the health insurance doesn't cover the full cost of the bill and the patient is unable to pay the remainder. So let's just look at an example. So my son had a bad sore throat a couple of weeks ago, and it was the weekend. And we thought, well, he needs a COVID test for sure. And we wanted to get results back as quickly as we could so that we knew whether or not he could go to school and all those types of things. And so we went to urgent care at Prevea on the weekend, and we had a lovely experience. Everyone was very kind and very nice. And he got a COVID test. He got seen by a nurse practitioner. He got checked in by the receptionist, checked in by the nurse who took vital signs, asked some basic questions, and collected some samples. And then he was examined by a nurse practitioner who took an additional history, performed a physical exam, recommended a treatment plan, gave us our prescription. And he had a strep test, which ended up being positive. And so this was our bill, right? So the bill for the strep test itself, interestingly, was $86, which was a big surprise to me because I used to work at the student health center and we charged $10. So that was a big eye opener. And then the visit itself, which is kind of everything else, is just shy of $400. And so we see a couple of things here. So one is that's a really high bill, right? So, the total was like $485 for what was a half-hour visit at the urgent care center. But we have to acknowledge that that's paying for a receptionist, a nurse practitioner, a lab tech, the custodian, the nice new building that they've just built. It was a really cold day, so helping to pay the heating bill and the electric bill and all those types of things. All the supplies that were used during the course of that visit, and the thermometer thing and the looky in your throat thing and all that. But also the computers and the computer system, the electronic health record system, and it's also subsidizing the billing department and all of the financial people behind the scenes that do the work to then send me this bill. Certainly that nurse practitioner did not get paid $400, I promise you. But so not only are we paying for all of those things, but we're also paying for the half of people who don't pay their bill. So what you can see is that my insurance only paid $240. All right, so you see that insurance payment, WEA Trust. My insurance only paid $240 of that visit. I paid $25 as a copay when we first checked in, and then in the end, I still owed $220.77. I have good insurance, right, as a state employee. This is the good health insurance that we have in this country. Part of the reason is we have so many people who do not have good insurance or who cannot pay the patient portion of a bill, that when I pay this bill, I am helping to subsidize all of the bills that went unpaid, right? So if you think about it, since about half of them go unpaid, all the rest of us are basically paying double all the time, right? Because these are nonprofit organizations. They can't operate as a loss, but they're not trying to make money either. They're really just trying to break even. So we're all paying twice as much as we should be because half the time people can't pay their bills.